We'll see some of those in a minute. And then, of course, you need to have the advanced workstation that comes with this machine to be able to interrogate the torrent, seriously, torrent of data that comes out of the machine. And unfortunately, one of the limitations of this presentation here is that I can't show you what it's like to take a workstation and interrogate the volume of data in real time. But it's very flexible, and you can say, okay, what's the question here, and then hone in on the body part you're interested in. I'll try to illustrate that with the following cases. So here's a proof of concept. This is a frontal view of a patient with a painful shoulder. And actually, we could already see signs of trouble here. There's a little lesion down there. A little piece of bone has been taken off the inferior glenoid. This, of course, is the clavicle here, the acromioclavicular joint, and the head of the humerus, and the coracoid process here. So we're looking at the shoulder from the front, and then we just ask the patient to do a simple maneuver to try and prove the concept, just basically internally and externally rotate their arm. And they were sitting, leaning into the volume of the scanner, so they've got gravity acting down, as it would normally do, on that shoulder, and they're going to rotate their humerus in real time. And this is what you get, and you can cine loop it, and you see this, that's real motion acquired in real time, gives you an idea of what we're starting to deal with when we're interrogating these data sets. Now, what you can do then is you can look at it from any position, and you can also slice bits away. And what I've done here is I've actually taken away the humerus just to leave the head of the humerus in location. And this, of course, here is the acromion process. And here is the subacromial arch height, and there is very narrow. And now what we're asking the patient to do is to do the thing that hurt them, which basically was this, okay, within the imaging volume. And as we play the video through, you'll see that, bang, what's happening is that part there, the humeral head, is coming and bashing into the acromion process and causing them pain. And as this was the painful moment in the whole movement cycle that I've kept for you here, bash, it's actually clonking into the acromion process. That subacromial arch height is being completely lost. So they'll be pinching the bursa and the cuff there, and that was why it was painful. But you can see the total imaging volume here from the mid-cervical spine almost down to the bottom of the scapula. That is the patient leaning into the volume, that cylinder of scanning volume that I talked to you about, 16 centimeters deep. So then we can put any other body part that will fit into the scanner into that imaging volume. And this is a patient with anterior ankle pain. And it'll be fairly easy to see. If you keep around this part of the ankle here, you can already see a little spur here. And you'll see, as they go through a range of dorsiflexion, clonk, that little bony spur is coming up and impinging on the anterior margin of the tibial plafond. Now, that, of course, is diagnostic in itself. And looking at CT scans as I do all the time, I'm used to that, and it's easy for me to appreciate it. But it's kind of not really, it's not, if you like, an image that, say, a patient or a clinician who doesn't look at a lot of CT scans can easily visualize what's going on. Far easier, I would say to you, to look at the three-dimensional build-up on the workstation. This is the frontal view and the side view, and now you can see this bony bump here. You can see it here. As I play these AVIs through, now you'll appreciate, you can see how that impingement is working. And so as a surgeon, you could show this to your patient and say, look, that's the problem, and I'm going to go in and I'm going to take that little bony bump off, and you'll get better. And I think there's a lot of power in medicine by being able to show the patient in a way that they can easily accommodate and understand what you're going to do to them. And this is probably the clearest thing, short of actually letting them look at their own operation, that they can appreciate what you're going to do to them. So it makes that explanation a lot easier, I think. Getting into deeper structures is often a challenge for imaging. We need to be able to get rid of overlap. We need to be able to see what's going on. And in particular, at the base of the skull, you've got a lot of overlap in the jaw, the base of the skull itself, the cervical spine, the soft tissue structures, the vessels, and so forth are all there. Now, this was a patient where we really just wanted to see what was happening to the atlantoaxial distance. We were worried that there was some instability there. But when we did this study, just in this conventional 2D representation, we could see that the atlantoaxial distance there was not significantly altering. This was another patient where we were looking at cervical spine dynamics, and this is the only one I'll show from the neck, really, because Nick's going to talk about that to you later. But again, we asked the patient to rotate their head, and this is the patient leaning into the scan volume, so they've actually got some gravity, the weight of their head acting on the neck. So we're trying to recreate a real physiological situation. And most of the rotation, as you can see, is occurring at the top here. This is dysfunctional motion. They've got very limited motion in the lower cervical segments. As I run that through again, you'll see they're pretty splintered low down, and at the top, there's kind of excessive rotation of the head. So if you like, it's an accommodated movement. It's not a true physiological movement. But there's a lot of learning curve to this. We have to know what normal looks like first, and I need to work with my clinical colleagues who can say, oh yeah, that's clearly abnormal, and that corresponds to what I find when I examine them. So it's the same old story for me as a radiologist. I have to piece together the story by extending my knowledge out to what the clinicians need to know, or have learned, so I can give them back a meaningful answer when I do my report. Again, this was a patient who'd had a repair done of their dens, and we needed to know, is the repair stable? Is the atlantoaxial distance here staying stable as well? Because the patient had a lot of pain. So we needed to know that those two things weren't causing pain. Difficult study, this one. There's a lot of kind of misregistration artifact because the patient was wobbling because it hurt them so much to do it. But by the end of it, and once I'd looked at it often enough and looked at it in multiple planes, I was happy to say the repair is stable and the atlantoaxial distance is also stable. I have a big interest working with the lumbar spine, and often the question is, what's the status of the spine? Is it stable? Where's the pain coming from? And a simple three-dimensional view here of someone who's had a lot of fusion surgery. You can see they've got interbody fusion there at L4-5 and L5-S1. There's a nice view down the foramen. As we come around, we can see these big bone blocks here of the posterolateral bony fusion. There's been a posterior decompression. You can see the big foramen there where the spinous process has been taken off. Another view of the foramen coming in here. And you can see what I've done to make this. I've actually, on the workstation, I've cut away the iliac crests. I've cut away the overlapping structures. And you can spend hours and hours making these pretty pictures. But, you have to think about what you're doing. Also, that volume you're seeing there, I can tumble in any direction in space. So I can look down individual outlet foramen. And just you can spend hours interrogating the data. But this is just a simple spin through to show you, where I start from. And the question is that patient stable or not? And we started doing flexion and extension studies in the scanner, effectively either a press-up for the extension or a sit-up for the flexion. And I know Nick wants to talk a little bit about this sort of the pump action that we see going on in the soft tissues anteriorly, but this is the extension maneuver, and here's the flexion maneuver. And you can see the change there in the abdominal contents, in the hollow viscera. But critically, all these levels, I'm quite happy to say, as far as I can see, that's a stable fusion. When we get into the realm of abnormal motion, things can become more complicated. This is a patient who has Harrington rods, getting a lot of pain, and the question is, how do we manage the abnormal motion segments? What's going on there? This is a patient doing flexion, and you can see there's quite a lot of abnormal rocking motion at the L4-5 level there. Here's the bottom of the Harrington rod, and already now you can see that there's almost like a rocker bottom of L4, gaseous degeneration of the disc, and when I run the movie through, again, you get a much more convincing feel for the collapse of that disc space and the abnormal motion, the rocking motion that's resulting from the rigidity of the motion segments above, leading to abnormal motion through that motion segment. So I'm able to interrogate levels in a much more confident way than by any other technique that I've got. And then you can really hone in on particular areas. This was a question, this is the pars intra-articularis. The patient had low back pain. We'd done conventional CT. We knew he had pars defects, but the question is, are they stable? Well, it's very difficult to say, and certainly you can't do fluoroscopy because of the overlap. And I looked at this one and I thought, well, maybe, I'm not sure. There's the pars defect coming in there. Looking at it multiple times, I'm not quite sure. But I used a slightly different orientation because I can vary the orientation in real time when I'm interrogating the data. These AVIs are just, if you like, snapshots. There again is the pars defect. And I think when you look at this one, you'll see it kick there at the end of motion. If you look at the anterior border, if you follow this anterior border here through to here, as we go through, you'll see it kick backwards there. And that's an unstable pars defect. So I was able to actually come back and say, no, in real time, when this patient does a sit-up maneuver, which was hurting him, by the way, position of pain, I can see this pars defect actually hitching. So it is an abnormal pars defect in as much that it's unstable. So we're able to refine the diagnosis in these problematic patients. And we're also able to refine the diagnosis in common or garden patients. This is a patient with known facet degeneration. She's got quite debilitating low back pain, which has suddenly flared up. What's gone wrong? Has she developed disc pathology? Well, when she does a flexion, you see pretty much that the lower motion segments are very splintered, hardly moving at all. Maybe we should expect that with the facet disease, but it's not explained to us why she's got pain. Certainly doesn't seem to be coming from abnormal motion in the disc spaces, because they don't seem to change barely at all. When we did this, we could see these big furry facets, which are her degenerate facets, and I thought, well, okay, they don't seem to be moving very much. And then my eye fell on something else, which is here. And if you look at this area here, you'll see there's just a faint band. If you keep your eye on that, suddenly click, it opens when she went into flexion. Again, that's explaining why she developed sudden pain. She actually fractured her pars. So in amongst all the overlapping disease, all the overlapping degeneration, I was able to hone in on a particular area and actually see an unsuspected pathology that was contributing to pain. So for me, this is the real power of the technique. It allows me to take what I already know from all the other tools that I'm using and refine problem cases, and they needn't be complex. This is a common or garden problem. How many patients do you see in your practice with lots of degenerate changes in the lower lumbar facets, and then suddenly they decompensate one day and they come and say, my back's got much worse all of a sudden. Trying to find out why can often be difficult, but the power of this technique, I think, can help you to determine unsuspected pathology and hopefully then come up with some kind of treatment routine for them. So for me, in summary, this dynamic volumetric CT for me is opening new windows into both common and complex pathology. It allows me to attempt to image in a much more functional way than I have been able to before. I recognize that there's a steep new learning curve to climb, and I need to continually talk to my clinical colleagues to make sure that I'm not making things up, which is very easy to do. I have to make sure that I'm respecting the dose limitations, because we all know that CT is so commonly used now. But I think if you're using it in a focused, targeted sense, it is legitimate. And I think that this kind of functional imaging, trying to add gravity, trying to add functional positioning, is the way forwards in musculoskeletal imaging. So in summary, I'd like to thank Paul Jenkins and his colleagues, and particularly Tony and Mike and the staff at the European Scanning Centre for allowing me access to the scanner and helping me to develop these protocols and sequences. Without them, none of this would be visible. And as I say, it's a team effort, so thank you very much indeed. What we're going to do now is to move on into another area, which is to introduce to you Dr. Marcus Banks, who is a consultant orthopaedic surgeon at Guy's and St Thomas's Hospital, who's going to look into another area where symptoms are common, the hips, but we're looking at new pathology in the femoral acetabular impingement story. And whilst you just get yourself set up for, very good, Marcus, of course, is using an apple. This is one of orthopaedic surgeons.
And here I am starting straight away seamlessly as a result of that. Good evening, ladies and gentlemen. Thanks very much for inviting me, Paul. I'm going to talk to you about femoral acetabular impingement. It's all the rage in hip surgery. At last, we have answers for some of our younger patients who actually have hip joint pain, whereas previously we didn't have the means to either diagnose their problem or indeed treat it. And I'm confronted really with an epidemic of young adult hip pain. They're often parents, they have jobs, they're in employment, they're educated, they clearly have access to the internet, to YouTube, and they're quite often parents of young children. And what they're struggling with really is not only can they not exercise to the extent that they would like to, but also they can't really actually live their day-to-day lives. They get a lot of discomfort, say, sitting at a desk, or maybe standing on a train on the commute to work. So these aren't trivial symptoms. These are symptoms that do affect patients' day-to-day life. In addition, this sort of huge emphasis on recreational activity, both in the media and obviously by the government as well, makes them feel even less happy about not being able to live such an active life. Now, I'm just going to talk to you about normal hip movement and ideal hip movement, and then compare it with the the kind of things that go on in impingement. These are a couple of individuals with ideal hip movement. This particular unpleasant individual, I'm pleased to say, is retired from cricket, but he's been replaced with an equally unpleasant one. So this is